In 2002, in San Vicente del Caguán in Colombia, the team was returning from an outreach activity in the bush, and we crossed through a hamlet near Los Pozos, where we saw the body of a little girl lying in the middle of the street. We asked the driver to stop to check if the child was breathing or not, but unfortunately the security rules didn't allow us to doing that, because armed actors were putting bombs underneath the bodies of the children to make them explode when someone was approaching. From that very moment, I learned that practicing pediatric in the tropics will be a very different thing than what I have done till then. It was not my first experience in the Global South, though. In the early 90s, I was in Jack Prager Clinic in Calcutta in India, where I learned everything that a pediatrician can learn about leprosy, but also how important is social factors in children's neurodevelopment in the children's home of the Missionaries of Charity of Mother Teresa in Middleton Row Clinic. But I learned how painful could be to wait in a hospital with a little infant in your arms with a severe pneumonia for hours and hours to be admitted in a public hospital. If I look at that time, early 2000 in MSF, there were not pediatric projects, there were not pediatric field positions, there were not pediatric regular or neonatal regular trainings, there were not advisors for pediatrics or implementation officers in any of the OCs. And the most similar thing to a neonatal or pediatric guideline, it was the last paragraph of an adult medical guideline at each chapter. However, and despite these, my first programs in MSF were purely pediatric ones. They covered the three transversal items were discussed in MSF at that time in the post-novel era. So the Access Campaign for Essential Medicines brought me to Bulawayo in Zimbabwe to treat children, a huge cohort of 1,500 with pediatric presentations of antiretrovirals, where it was shown that prevention to mother-to-child transmission was not functioning at all. Operational research, and particularly of optimizing combined therapies, brought me to a rural area in Ethiopia to treat uncomplicated malaria with artemether, lumefantrine, and artesunate, respectively. And the Drug for Neglected Diseases initiative brought me to Tarija in Bolivia to treat children with the disease of the poor, a neglected disease, Chagas disease, with a very old drug, with a huge potential of making side effects, severe ones, and not child-friendly presentation, which is benzimidazole. At that time, a malnourished child was in a tent till they reached the aim weight, treated with milk and porridge done with BP 100. It was the time where treating HIV was purely based in clinical science and evolution, and treatment failure was just suspected in clinical grounds. Vaccination was just a reactive thing in emergencies, and it was an MOH responsibility. Chronic diseases, if in some projects were treated with crushed pills of salbutamol, for example. And newborns were not in our IPDs. Where were they? Were at home. It was a time where proposing to treat hepatitis B or C in a country like India was said as this is not MSF. But also, using rapid diagnosis tests were a continuous fight because people was not relying as in comparison to their gold standards, not only for malaria but other diseases. Psychosomatic symptoms were treated with painkillers, and we put in the table that perhaps we need to go into the psychological treatment of these patients, especially in conflict settings. And in these same settings, we were not able to offer treatment for victims of or survivors of sexual violence, or even propose termination of pregnancy. And we were having as well some bizarre clinical pictures in places where extractive industries were present. Things in MSF has changed. MSF has evolved a lot. There has been a huge transformation in this organization, and innovative things has been done. So now, yes, we do have pediatric projects. We do have pediatric field positions. We do have neonatal and pediatric guidelines. I would have loved to have these neonatal guidelines in Medan, in Indonesia, in the late 90s, to treat especially premature babies in a hospital setting. We do have advisors and medical implementer officers in all the OCs. We do have regular trainings or trainings worked for pediatrics and neonates. And we use quite widely telemedicine and algorithms for e-health. In the field, we do treat nutrition in an ambulatory basis with rapid, ready-to-use therapeutic food. We have now the possibility and the standard of viral load in HIV programs. We have a lot of devices and blood tests that we didn't have in the past. We use POCUS quite widely as well. We do have better tools to treat chronic diseases as pressurized nebulized salbutamol or oxygen concentrators, and even CPAP. We do have Gen Expert to help us to diagnose tuberculosis, still a challenge. We do have vaccines for vaccination in MSF programs, in regular programs. We tackle violence with mental health sessions, and we do offer clinical care to survivors of sexual violence and even termination of pregnancy. And we have much more oriented things for all these diseases that in the past we didn't have to. However, there's still challenges for the future. I would love to have neonatal and pediatric intersectional guidelines. I would love to have a better career management of the pediatricians. I would love to have all these trainings that, for example, helping babies breathe or essential newborn care trainings in every field to do it, and also to tackle things as integration of pediatric activities in every program and assuring the continuum of care to treat the patients with the highest quality. In terms of activities and programming, we need, in my opinion, to strengthen palliative care, antimicrobial resistance. Things in chronic diseases, we still have a lot of room to improve. We do have also in environmental planetary health. It would be lovely to have a multi-test diagnosis for differential diagnosis of fevers. And we do need to tackle psychiatric conditions, but also social conditions and how far we go in protection services, especially in conflict settings. So I have talked about the past, I have talked about the present, I have talked about the future. But what is my take-home message? And it is related to the quality of care that we give to the children. I will tell you a story that happens to me when I was a resident in Madrid. And we were receiving a child in the intensive care unit after a pulmonary atresia surgery. We were around the bed of this little child, an infant, and the boss told us, there's only one resident that is doing the right thing at this moment. We look at each other not knowing at all what was going on and what was the answer. But yes, all but one were looking at the devices, at the blood pressure, at the oxygen saturator, etc. There was only one that was looking at the child. That was the answer. So remember that in the past, in the present, in the future, the child will be there. To increase our quality, we really need the quality of medical care. We really need to be proximate to the child, to treat them with respect, dignity, and with humanity. The human touch is very important, and this is not needed a device or whatever. We need to look to the child, we need to listen to them, even if they are not able to express themselves with words, because they talk to us. They talk to us, and we just need to look to them. Remember also to make them engage in the dialogue, even if they don't express, and also their families. We need to know what they think about what we are doing. Please do not forget that the most important thing to improve the quality in pediatrics is the child, and looking at them and treating them with respect. Thanks very much.